Good morning, everyone. I'm privileged to be amongst such esteemed speakers today, and I've been very impressed by the talks already about in discussing surgery. There's been brain surgery already from Caroline, and Grant's already talked about spinal surgery. So that's all really interesting. I'm delighted to talk to you today about how nutrition has become a very important part of my neurosurgical practice. And for those of you who don't know me, I've worked at most of the major hospitals around Queensland, and my private practice now is based at the Brisbane Private Hospital, just up the road. So we're going to talk a little bit about back pain today. It's a very common complaint. I was just wondering, can I have a show of hands from the audience who has experienced back pain? So that's pretty consistent. That's pretty consistent with the statistics. Most of you, 80% of people will suffer an episode of back pain throughout their lifetime. The lifetime prevalence, the point prevalence is about 10 to 30%, and unfortunately, one in 10 of you will be unlucky enough to have a complaint that becomes chronically disabling. And what does this cost the community? It's estimated to be worth about $2 billion in health service dollars. But putting that into perspective with diabetes and obesity, it's quite small, which compared to $50 billion. Now, what's the underlying reason for the prevalence of back pain? Fundamentally, it boils down to dysfunctional movement patterns and premature deterioration in the strength and condition of the musculoskeletal system. Now, is it likely that these individuals suffer spine pain? No. Why not? They have beautiful, natural, functional biomechanics, and this involves flexibility, agility, and appropriate strength and conditioning for the tasks required of them. Young or old, the natural biomechanics of the human body to maintain healthy movement patterns are identical, and this is beautifully displayed by the Olympic weightlifter and the toddler, engaging in natural, efficient, functional movement. So what goes wrong? Unfortunately, we've maladapted to our unnatural lifestyles. We sit for too long, for example, attending seminars like today. So I want you all to tuck your backs into the back of your chair and maintain that natural position of your spine. Some of us drive for too long, we work long hours, and sometimes we take our dogs for a drive. We've all been taught to bend at the hips and keep our back straight, but unfortunately that's not as easily done with our lifestyles of poor nutrition, leading to poor joint mobility and musculoligamentous tension. And we've all heard the term tight hammies, and there's a very easy test for that. Trying to keep your bend at the hips and bending forward, and see how far forward you can bend before you start to feel that tension in your hamstrings. Now, this leads to a breakdown in the mechanics of movement and eventually the nervous system that sequences muscle contraction, so we become uncoordinated and we literally forget how to move properly, or we forget how to move the way our body was designed to move. So, but the good news is that it can be relearnt, and just like someone who's taken up golf at an older age, they with some appropriate coaching and lessons, they can learn within a few months how to hit a beautiful golf shot. So previously, how did I treat my patients with back pain? I spent years and years learning how to surgically stabilise the spine. So my first port of call was to pull out the hammer. Internal fixation, fusion, artificial disc replacements, that was what I loved to do. I didn't have one conversation with my patients about nutrition and functional movement, which was the most important treatment of all, but I didn't know that at the time. What do I do now? My practice has changed immensely in the last few years. Movement training and nutrition advice is always required, and thankfully for my bank manager, sometimes surgery is required. This is my typical patient with low back pain problems, and this lady is awaiting surgery. Now, I can perform her surgery tomorrow. We can accommodate her body habitus, and we can look after her metabolic derangements. We have spinal tables that can accommodate a patient weighing in the order of 150 kilograms. We have special equipment that still allows us to do microsurgery in large people. This is the top picture is our tray of retractors called the fat retractor tray, and this is so that we can put the blades into the subcutaneous space and hold the soft tissues out of the way so that we can do the more delicate surgery on the nerves. But this is a wake-up call. It's not to build deeper retractors and stronger spinal tables, but it's to address the issue causing the problem in the first place, their body habitus and their nutrition and the movement biomechanics. And I'm disappointed that throughout my training, not 1 minute was dedicated to this critically important topic. Patients are bigger, sicker, and less physically active. This means they have polypharmacy, using lots of medications. They have comorbidities that are particularly related to their insulin resistance and metabolic syndrome. And they are resistant to the perioperative rehabilitation that is critical to good outcomes from back pain surgery. You cannot just operate on someone's spine and expect a miraculous recovery. Efficacious rehabilitation is required in every case. And unless they have a healthy metabolism, they are resistant to that physical rehabilitation. The pathology is also changing in spine surgery. When I started practice, this condition of epidural lipomatosis was quite rare, and it was really restricted to individuals that had imbalances of steroid and anabolic hormones and people who abused anabolic steroids, for instance, bodybuilding. But I'm pretty sure that grandma is not shooting up performance-enhancing anabolic steroids for her next weightlifting meet. Yet she's presenting to me now with central adiposity and epidural fat that's squashing her spinal cord and requiring surgery. The slide on the right is a biomechanical simplification of what happens with the forces that span the motion segments of the spine. And these forces need to balance each other off. So if you imagine the front of the body being here and having an extra bag of cement weighing 20 kilograms in front, this force is going to be very large at every level. And if you're going to stand upright, it has to be balanced off by a force on the other side of the seesaw. What happens when this force starts to balance that off? You then get premature degeneration of the discs and the joints of the spine, and this leads to inflammation and pain. Now, this is before and after I started to put the puzzle pieces together. Unfortunately, it did take me about 15 years to put those puzzle pieces together, but without any real effort at all, and just some very simple changes to my nutrition, and particularly breakfast. And my lovely wife was happy to get up a little bit earlier and cook us a hot breakfast every morning, bacon and eggs, and we just threw out the Weet Bix and loaves of bread and orange juice, and I started to notice that I went from sickness to feeling reasonably athletic. And I was staggered to find that at the age of 41, I actually had a six-pack. And I promise you that wasn't from doing sit-ups or tummy crunches or anything fancy. It was purely, all of you have a six-pack, it's just hidden. And it's purely from changing your nutrition. And I also had high blood pressure. I nearly failed a life insurance medical check, and these were the wake-up calls. Now, this is the crux of the problem. The conventional teaching is so entrenched and reinforced at every turn in the patient's lives. I was faced with the problem of how to help patients truly believe the polar opposite approach. So I identified the common and most powerful barriers that have to be broken down for each patient, and I simply had to step through them one by one. The most powerful ones were that they had this obesity and low back pain problem because they had pain that stopped them exercising, or they had to exercise more and eat less, or that it was in their family genes, because quite often they'd have siblings that were large as well, and their parents were large. Patients have a very rudimentary understanding of carbohydrates. Some patients thought carbohydrates were in all foods, and they don't distinguish between carbon and carbohydrate. They didn't really understand what food was: carbohydrate, protein, and fat. Patients who did have a bit of an understanding of carbohydrate thought they had to have some carbohydrate, otherwise, they'd faint or they'd start to get shaky, and they need carbohydrates for energy. And very powerfully, the patients trusted GPs, and other specialists were giving these mixed messages. So it was terribly difficult to unravel this for patients. And I understood that because I had the same misconceptions as well for pretty much most of my medical career. So where to start? I think it's important to tell patients that they're not unique in having this problem of obesity and low back pain. 2/3 of adults are overweight or obese, and 1/4 of our children are overweight. And I used to suggest to patients just to pop into the local shopping centre and have a seat and just count the people walking past, and just tally up in your mind how many of those people look like they're overweight and how many of them look lean. And the stats are consistent. And things started to go wrong in the 80s when the food pyramid and the healthy eating guidelines were published. Now, the big fallacy number one was to eat less and move more to lose weight. Now, I explain this to patients that obesity is a hormonal condition, not a condition of physical inactivity. Now, overweight grandma, overweight businessman, they're not going to lose weight by joining a gym without some modification to the nutrition. The hormonal condition, however, does cause one's physical inactivity and poor eating habits. That's physiological. And that's what makes people think that the reason why they're overweight is because they eat too much and exercise too little. And that's just like an infection that causes a fever. Treating the fever with Panadol doesn't cure the infection. I didn't like to bombard patients with too much medical science, but the one bit of science that I need my patients to understand is about insulin, and essentially what insulin does to the body, and that too much of it is bad. And the main actions that I wanted patients to understand about insulin was that it caused fat deposition, it made them tired, and it made them hungry. And I labelled this the hormone of hibernation, which made it very simple for them to conceptualise. And then once they understand that too much carbohydrate is bad for you, affects you negatively, once they understand that too much insulin in their body affects them badly, the next question is, well, what pushes my insulin levels up? And this slide that I show them is very simple. It's not conjectural at all. There's no contention about this, the effect of these macronutrients on insulin levels. And carbohydrate is the main stimulator of insulin release from the pancreas. Some patients don't understand what carbohydrates are. The practical approach is that I just direct them to the standard food pyramid, and there they are at the bottom, being unhealthily consumed in abundance. I also like to explain the glucose bricks analogy, that complex carbohydrates are essentially the same as simple carbohydrates, just in a different, more extravagant shape. Fundamentally, however, they are both made up of individual bricks of sugar, once broken down by the body's enzymes. So a Mars bar and a bowl of pasta are really not too dissimilar in their metabolic actions on the body. It's also important to explain that the body can make more than enough carbohydrate for energy, and that although they will still eat some carbohydrates, they don't actually have to maintain a healthy lifestyle. And the final picture on the bottom right just quantifies carbohydrate amounts in grams, that then allows us to prescribe their carbohydrate intake for certain goals. And it's amazing how many folks are lost for what to have for breakfast when they're told that they can't have carbohydrates. Like, you mean I can't have my Weet Bix anymore? I can't have my toast? Well, it doesn't take too much effort to then show them what you really should have for breakfast, and then they usually smile and they said, "Oh, that's what we used to have for breakfast, 30 years ago," or "That's what Mum and Dad grew up with." Now, what about the fat discussion? This is a little bit more challenging, but I found that these type of graphics have the most impact on legitimising my claims. The pie graphs showing two types of diet, the ancestral diet and the currently recommended diet, are vastly different in the proportions of fat and carbohydrate, and this has a fairly powerful impact on them. Time magazine, it's viewed by millions of people around the world. It legitimises the claim. Look at what they put on the cover in 1984, and look at what they put on the cover in 2014. It just stimulates some curiosity in the patient that, hang on, maybe it's not that bad for me. The picture of a baby breastfeeding. This baby's only form of nutrition in their first year of life is milk, super high in saturated fat. It can't be that bad for you. And I challenge them to an alternative, higher fat, lower carb food pyramid. Just try it for a few months. You've got nothing to lose. You might be very surprised. And of course, providing them with a bit more scientific literature that they can bring to their GP or specialist. And there's an abundance of supporting science. This is also when the topic of cholesterol comes up. And again, it's quite difficult because many patients are on cholesterol-lowering medication that goes hand in hand with their obesity and dyslipidemia. They may have had a heart attack. They may have a coronary stent, keeping their blood vessel open. And they're terrified of cholesterol. I inform patients that the cholesterol-lowering medicine is quite conjectural and contentious in the medical field, and that companies that make cholesterol-lowering drugs may just have a conflict of interest, and with the profits in the magnitude of billions, not millions, they have the power to influence people at all levels, including politics and including medical teaching. And I just say, look, ask your GP, do I really need to keep my cholesterol this low with these drugs? Or do I need to fear cholesterol in my diet? What's the evidence? And they'll often be shown a picture like this that shows very, very impressive reduction in risk with a cholesterol-lowering drug. And I then draw their attention to the little asterisk next to the 36%. I'll say, well, why? Why does this 36% have an asterisk next to it? This asterisk actually says in small print at the bottom the true benefit, and the true benefit is about 1%, and that benefit may not actually even be from lowering cholesterol. It may be from a different process called plaque stabilisation. So how does 1% get expressed as a 36% benefit? This is statistical deception by using fancy maths and an expression called the relative risk reduction. It's sort of like going to a shopping centre that has a 50% sale on, but the day before that 50% sale, they marked up the prices by 49%, and then told you that there was a 50% sale. The actual benefit that you're getting as a shopper at that store is minimal. And of course, we have to back that up with science as well. And my patients leave my office with all this big bag of scientific journals. I like to also show some diagrammatics to patients about how important cholesterol is in every cell of their body. And quite often they've come to see me with a brain surgery problem or a spinal cord problem. And I explain to them that cholesterol makes up a huge proportion of your brain. It makes up a huge proportion of your nervous system, your spinal cord and your peripheral nerves, and that the symptoms that they're presenting with, like pins and needles and numbness and tingling, it may not actually be because of a surgical problem. It may be because of your nutritional state. So we have to seize the moment, and after a 45-minute conversation with my patients and only having a 30-minute time slot, I'm running late again, and my secretaries are knocking on the door saying, hurry up, hurry up. We then need to help them on their next step, because once they've gone home, we want to keep that momentum going with that curiosity for knowledge about their nutrition. So I make it very clear to them that my practice is just a phone call away, an email away, and I provide a 24-hour support for patients with lots of educational materials provided in a hamper, and also online resources, and my practice nurse and my clinical assistant are available every day to talk to them and help them through their little areas or questions and misconceptions. Just like to show you a couple of quick patients. This is a lady who had a spinal cord problem, and she presented to me with other symptoms of depression, and she was obese, and she was very lethargic, and she also happened to have an unhealthy disc prolapse that was pushing on her spinal cord. And obviously this was a surgical problem, but as well as talking to her about the surgery, which was an artificial disc replacement in the neck, we also gave her that same talk, the same information that I've just presented. And I saw her 6 months later, and it was just heartwarming to see the transformation that she'd made. And she was so proud to bring in her 7. She said she brought in 5, I think, and the other 2 were certificates. But she had run in 7 fun runs because she just felt she had an abundance of energy. I didn't recognise this lady when I saw her again, and she was more grateful for the change in her overall health than me protecting her spinal cord. I'll see if I can just introduce this video as well, and you can just see for yourself the changes that people make when they're not medically trained, but just giving them the right advice in a simple way. Joe here, and Joe's a patient of mine with significant problems with back pain, and I first caught up with Joe back in 2014 around April, and we identified some pretty significant spinal problems, which I'll show you now. This was Joe's lumbar spine. As you can see, he's got quite a significant spondylolisthesis there. Tell us how heavy you were when I first saw you, Joe.
Well, 106.
106 kilograms. And what would have been your standard breakfast and lunch and dinner? What was your typical breakfast a year ago?
Most days it was muesli, usually milk or muesli and yogurt, cuppa, and lunch all depends where I was. I might have 4 pieces of bread and peanut butter.
So that would be like morning tea or pre-lunch sort of.
Pre-lunch, yeah.
So were you feeling peckish around morning tea? Did you have that sort of that hunger sort of set in around 10:30, 11 o'clock?
Yeah.
And you really felt like you had to have something, and then you had some 4 slices of bread.
Yeah. My wife goes to the gym every morning, so when she came home, we'd have some lunch, and it'd probably be a smoothie, or I'd have some more bread. A fruit smoothie. Yeah. Fruit smoothie or vegetable smoothie or fruit.
Fruit. Like, how many pieces of fruit would you chuck in the smoothie?
It'd be a couple of bananas, frozen bananas and frozen mango.
Yep. And what was a staple dinner meal?
Oh, the usual meat, veggies, potatoes.
Yep.
And enjoyed meat potatoes.
Yep.
And,
how many would you have a full baked potato on a plate?
Oh yeah, a couple of them. Yeah.
Couple of those. You came to see me about your back problems, and did it surprise you that we spent a fair bit of time talking about your weight?
Yeah.
And we know that weight has a pretty significant influence on back pain.
Yep.
Are you still having your 4 slices of toast at morning tea?
No.
Are you afraid of having an omelette and bacon and eggs for brekkie?
Oh, I've had bacon and eggs for breakfast a few times.
Yep.
And I've had boiled eggs and a vegetable smoothie at
Yeah.
lunchtime.
Vegetable smoothie, not bananas and mango smoothie, right?
Yeah.
And have you cut back a bit on things like pasta and potatoes and
Yeah.
and
I tried. Excuse me. I tried their cauliflower rice.
cauliflower rice? Do you feel quite satisfied after a bacon and eggs brekkie? You don't sort of have that morning tea craving for four pieces of bread anymore.
No.
That's wonderful.
Yeah.
And let's have a look at you now. Stand up for us, Joe. And
Slide on.
slide on, yeah. And Joe, tell us what's your current weight?
This morning in the birthday suit, 85 kilo.
85 kilograms, down from 106 kilograms. So that's over 20 kilograms of weight loss. And the big question: what is your back pain like? What's your back pain feeling like?
It's less, but it's amazing, that I've. It's like carrying around a bag of cement.
20 kilograms everywhere you go, right in the middle of your belly.
Yeah.
And okay, well, Joe, thanks so much for talking to us about that, and I'm sure the people in the audience will love hearing and appreciate your story, and hopefully you'll be able to help other people as well. So Joe still had to have his surgery. We actually did his surgery last week, and he was in and out of hospital in 4 days. At 106 kilograms doing his surgery then, I lose sleep over this type of operation. It's a real challenge, but his was easy. And he just bounced out of hospital. He got straight into the rehab the next day. So there's something else is happening to these patients when their metabolism changes when it comes to where I'm interested in with their recovery from major surgery. Just the last couple of slides. My new challenge is hospital nutrition, and if anyone's interested in some further research in the brain, cerebral vasospasm, which is part of a condition that one gets when they have a stroke, and its relationship in insulin resistance, because I think there's a link there, and I think we could make a massive difference to survival rates from stroke. So thank you very much.